the Emergency Medicine channel. As a part of EM Rapid, today we are going to discuss about burns and compartment syndrome. So, the most common burns, which especially in children, is scald, secondary to exposure to hot liquid. And most common burns which present to the hospital, and that too especially in adult, is because of thermal burns, secondary to flame injury. And other type of burns are electrical burns. So in an electrical burn, there will be usually an entry wound and an exit wound. And because of the tension, if it is a low tension electrical burns, it can interfere with the SA node function of the heart. And if it is high tension wound, that can cause direct damage to the myocardium. So along with the effects of burns, there will be a lot of effects, dysarrhythmias, everything that will affect the heart. And if it is a direct current or a DC current, this patient is having higher risk of asystole. And if it is because of a AC current or an alternating current, this patient will be having higher risk of ventricular fibrillation and ventricular tachycardia. Then other type of burns are inhalational burns, or there can be chemical burns. So if it is a chemical burn, depending on what it is, depending on if it is an acid or a base, there can be necrosis. So if it is an acid, there can be coagulative necrosis, and if it is a base or an alkali, there can be liquefative necrosis. Another type of burn is radiational burns. Radiational burns, there is ionizing and non-ionizing radiation, and it can be from the environment, or it can be because of any from any chemicals or any toxic gas productions, or from directly from the sun, or it can be iatrogenic, secondary to radiotherapy. And the most common cause of immediate death in case of burns is because of the suffocation. And most common cause of early death is because of the hypovolemia. And the cause of death in late burns is sepsis, secondary to sepsis. So sepsis can be because of organisms like Pseudomonas, Streptococcus pyogenes, Staphylococcus aureus, and some viral causes are HSV. Okay, so suppose a patient present to the ED with burns. In the primary survey and resuscitation, what all things to do? So first, if the burning process is continuing, stop the burning process. Okay, for that we need to wash with copious amount of saline. Remove the clothes of the patient, including the jewelry, wristwatches, everything, because these can cause a compressive effect on the patient, and this itself can increase the burns. So remove all those things. And if it is a thermal burns, we can use for irrigation, we can use cool running water, and irrigation must be done up to 20 minutes at a temperature of 15 degree. And if it is a chemical burns, better use warm running water for 15 minutes. And because of the excessive burns, and the skin will be damaged, and a lot of skin will be exposed, and subcutaneous tissue will be exposed, so this patient can eventually go into hypothermia. So hypothermia can be prevented by covering the patient and using cling film. Suppose patient is having a burns area over the chest or the limbs and all, use cling film. That can reduce the pain, and that can reduce the hypothermia of the patient. Okay, so note one thing, that while we are using cling film, do not use it over the face, and if it is involving any limbs and all, do not cover the entire limb with cling film, because that can cause compartment syndrome. Now next we will be approaching as a primary survey in the airway. So what all things can happen in the airway? So airway compromise can happen because of direct inhalation of the burns or the smoke, and there can be thermal burns inside the oral cavity, and because of the exposure to burns, there can be massive edema. So these things can affect the airway. And what will affect the breathing and ventilation? So there can be swelling in the airway, and the upper airway especially it can be because of the direct exposure to the flame, and lower airway swelling can be because of the exposure to the steam or the smoke. Then inhalation of the substances can cause chemical alveolitis that will affect breathing. Then exposure to the toxins, especially carbon monoxide and cyanide. So carbon monoxide exposure will usually come when this patient is exposed, is getting burned inside an automobile or a car or a factory like that. So carbon monoxide poisoning can also happen, and cyanide poisoning usually occurs if the burns is occurring in a house. So both will cause metabolic acidosis, that too lactic acidosis. So carbon monoxide can cause type A lactic acidosis, and cyanide can cause type B lactic acidosis. That can also affect the breathing. And secondary to the burns to the chest wall, there can be deep burns, that is called as an Escher. So what will happen is the entire chest wall, if it is getting burnt, there will be deep burns to that, and the patient will not be able to breathe properly. So that itself can cause a restriction to the breathing. That can also impair the respiration. So if airway or breathing is affected, this patient will require intubation. And if there is Escher over the chest wall, then this patient will require Escherotomy. Escherotomy is actually opening up of the Eschers. That means cutting through the anatomical lines up to the fat level, so that there will not be any restriction in breathing. These are the indications of early intubation. So early intubation is indicated if there are signs of airway obstruction, if the burn total body surface area is more than 40 to 50%, if there is extensive and deep facial burns, if there is burns inside the mouth, and if there is significant risk of edema over the face or over the airway, that can cause airway obstruction after some time. And if the patient is feeling difficulty in swallowing, that means there is some edema that is developing. And if there is any signs of respiratory compromise, and if the patient is having low sensorium, and if we are planning to transfer the patient to some other center. Coming to circulation, so there can be capillary leak secondary to leak of the inflammatory mediators. So because of that, capillary leak will be there, and the intravascular volume will come down. So in this patient, we need to place an IV access. We need to calculate what is the percentage of burns that has happened to the patient, and we will have to, according to the percentage of burns, we will have to hydrate the patient, and we will have to monitor the urine output also. So place IV cannulas, catheterize the patient, and monitor the urine output. We should note that over resuscitation can increase the edema and can increase the depth of progression of burns, and can cause compartment syndrome, even abdominal compartment syndrome. So depending on the requirement only, we need to hydrate the patient. So this is the classification based on the depth of the burns. So there is superficial burns, there is partial thickness burns, and there is full thickness burns. Okay, so superficial burns usually occurs up to the level of epidermis, and superficial partial thickness burns affect the epidermis and the superficial dermis, and deep partial thickness burns affect the epidermis and superficial and deep dermis, and full thickness burns means it will involve the epidermis, dermis, and the subcutaneous tissue. So superficial burns, the cause can be either it can be because of any sunburn or exposure to any sunburns or exposure to a hot object, and usually the skin will be intact, it will be dry, red, and it will blanch with pressure, and it will be usually painful, and it will heal within 3 to 6 days. Superficial partial thickness burns can be because of any scald or small flashes, and there will be blistering, the skin will be moist and red, and it will usually blanch with pressure. And the sensation, it is usually painful to temperature and exposure to any air movement or wind. And healing usually occurs from 7 to 20 days. And deep partial thickness burns can be because of scald, flame, exposure to oil or grease. There can be blisters, and it is usually wet and waxy, and the color will be very variable, and it will not blanch with pressure. And other thing is, it might be painful or sometimes it might not be painful. And the pain will be uh, usually there if the patient, if you are giving a deep pressure, and if the healing time will be more than 21 days. And if it is full thickness burns, it can be because of any scald, flame, steam, oil, grease, chemical or electrical exposure. And the entire area will be very much waxy, white in color or gray in color, and or it can be charred or black in color. It will be very dry and elastic or in a waxy appearance. There will be pain only on deep palpation, deep pressure, and there will not be a complete healing. So these are the images based on the classification. So we discuss about the first degree, which is involving the epidermis. Second degree partial thickness, it is involving the epidermis and superficial dermis. And second degree deep burns, that is involving the epidermis and the entire dermis. And third degree burns, which will involve the epidermis, dermis, subcutaneous tissue. And fourth degree means it will involve the epidermis, dermis, subcutaneous tissue, muscles, tendons, bones, everything. Okay, so and pain, it will be present only up to superficial dermis. After that, the pain also will come down, and the prognosis also bad. Now, why we discuss about the depth of the burns? That is for the management of the patient, and we need to calculate the burns. So, in first degree burns, it is usually not required and not included for burn size calculation, and no IV fluid replacement is required. Only oral fluid replacement is required if at all required. And from the superficial partial thickness burns to full thickness burns, we will be calculating for the percentage calculation of for fluid resuscitation. So how to calculate burns in a patient's body depending on the area involved? So we have the Valle's rule or the rule of 9. Okay, so depending on the area of burn involved, we will be calculating the percentage of the burns. Suppose if the patient's face and head is burnt, we will be giving a total score of 9. And if the patient's anterior chest is burnt, the patient will have a score of 9. And if the posterior chest is burnt, then also patient will get a score of 9. So if anterior and posterior is involved, patient will be getting 9 plus 9, 18. If the anterior abdomen is burnt, then it will be 9. And if the posterior part of the abdomen or the thoracic region is involved, then patient will have a score of 9. Upper limb, both anterior and posterior both included, patient will be getting score of 9. Whereas in lower limb, anterior lower limb will have a score of 9 and posterior lower limb will have a score of 9. But in upper limb, it is only 9. Total score of 9 will comes for anterior and posterior upper limb. Whereas lower limb, anterior and posterior both will have a score of 9, 18. Okay. And external genitalia will have a score of 1. This is same itself. Now another chart is Lund-Broder chart. It is actually used because the Valle's rule or the rule of 9 is not very good for children, because they won't be getting approximate percentage in children because of the difference in the surface area, because their head will be larger in children. So we need a different scoring system for children. So for that we have the Lund-Broder chart, and here depending on the age of the patient, the values, the percentage will vary. So especially in case of head, in case of the thigh and leg, as the age differs, the percentage also will differ. And the rest of the part, the upper limb, the arm, forearm, hand, the gluteal region and the foot region will be having approximately a fixed score. Rest of this score will vary according to the age. Now we have discussed about the percentage of the burns, and we have discussed how to calculate the total body surface area, and how to classify the burns depending on the depth. Now after getting these two things, now we will have to decide how much fluid resuscitation to be given to the patient with burns. So if it is a flame or scald, and if it is an adult or a older child, we use the Parkland formula, modified Parkland formula, that is 2 ml of ringer lactate into patient's body weight into the total body surface area calculated according to the rule of 9 or the Lundbroda chart. And this patient, the total fluid requirement is given to the patient. The half of which is given in the first 8 hours and the next half is given over the next 16 hours. So total 24-hour fluid requirement is calculated based on this formula. And urine output target is 0.5 ml per kg per hour for an adult or older child. If it is children less than 14 years, the formula is 3 ml into body weight, 3 ml of ringer lactate into patient's body weight into total body surface area, and half of it will be given over 8 hours and the rest half over 16 hours, and the urine output target is 1 ml per kg per hour. And if it is an infant or young child, it is same as that of children. And in case of electrical injury, in all ages, the formula is 4 ml into body weight into patient's total body surface area, and the urine output is also, target is also little bit high, 1 to 1.5 ml per kg per hour until urine clears. So this is the how to resuscitate the volume. Okay. Next is, so we have discussed about the airway, breathing, circulation. Next is disability. Main disability will be the pain. So pain, usually pain management, initially we have told cling pressing will reduce the pain. Opioids are usually used for pain reduction in case of burns. Try to avoid NSAIDs because that can cause, especially in elderly, that is contraindicated, especially if there is any renal failure or anything. And the burns patient is having a higher risk of rhabdomyolysis and all. So try to avoid NSAIDs, and the drug of choice is opioid for pain. And exposure also we have discussed that there is higher risk of hypothermia. So adequate hypothermia prevention is required for such patients. And coming to secondary survey, we need to document the urine output, the fluids given. So strict IO chatting should be documented, and the pictorial diagram of the burn depth and area involved, and what all blood samples should be taken and what is their importance. So we need to take the initial CBC coagulation profile and cross matching for resuscitation. These things should be taken. Then ABG and co-oximetry to find the carbon monoxide level and other glucose level. Then renal function test, electrolytes. These things are important when it comes to the late management of burns, and especially to monitor the patient for hyperkalemia or any pre-renal failure. And CK can be also be taken to look for any features of rhabdomyolysis. Pregnancy test is important in case of females. Chest X-ray before intubation and after intubation, and features of chemical alveolitis, chemical pneumonitis, these things will only happen more than 24 hours. So for that, chest X-ray is important. And ECG monitoring and cardiac monitoring especially is important in case of electrical burns, because we have already told there is high risk of arrhythmia. Okay, and other adjuncts like gastric tube insertion, especially in intubated patient, sedation and analgesia, adequate wound care, antibiotic, and tetanus immunization also should be given to these patients. Okay, so when to refer a patient with burns to a burn center? If the patient is having a partial thickness burns more than 10% of the total body surface area, or if the patient is having a burn over the face, hand, feet, genitalia, perineum, or major joints, or if the patient is having third degree burns in any age group, or if the patient is having electrical burns including lightning injury. For monitoring of arrhythmia and ECG monitoring, we need to refer to burn center. Then if the patient is having any chemical burns, inhalational injury, or if this patient is having any, if the patient is having any pre-existing medical disorders that can complicate the management and that can prolong the recovery or that can cause mortality. Then any patient with burns associated with trauma, depending on the severity of the trauma, we need to plan on referring. Or if the patient is a child and the center where the patient is managed initially doesn't have the facility to manage children, such children should be referred. And any burns to a patient that is affected socially, emotionally, or any rehabilitative intervention, if at all required, should be referred to a burn center. An admission, that is a referral, and admission in burns is required if there is more than 10% partial thickness burns in children and more than 20% partial thickness burns in adult, or if any full thickness burns or burns secondary to electrical or chemical burns or airway burns should be admitted. So we have discussed about the burns management. So this is a summary. So first we will be primary survey, airway, breathing, circulation. Early intubation is indicated in case of burns because as the edema increases, intubation will be difficult. So early intubation should be indicated. Supplemental oxygen and ventilation, IV access and IV fluid resuscitation. Remove all the injurious debris and clothing from the patient. In the secondary survey, head to foot examination, calculating the surface area based on rule of 9 or Lund border chart. Or if we don't have these charting, there are different chartings for calculating the burn surface area. Or we can, if we don't know both, we can at least use patient's palm to calculate the total body surface area. So patient's palm will be 0.5%. So based on that, we can determine. Then estimating the depth of the burns and fluid resuscitation according to Parkland formula and monitoring the urine output. Now, if the patient is having inhalational injury, we need to, and if we have intubated the patient, early intubation and lung protective ventilation, that is low tidal volume ventilation is required. And if there is any circumferential burns, we will, over the chest, we will have to monitor the ventilation and we need to plan on asherotomy. Some people might be having a doubt what is asherotomy and what is fasciotomy. Asherotomy is actually to open up to the fascia, up to the fat. Fasciotomy is opening the entire compartment of the limb. So usually asherotomy is required in cases of burns and it is in immediate management. Fasciotomy is usually required if the patient will develop a compartment syndrome, which is a late complication of burns. So in such patients, we not like asherotomy, we need not only up to the fat, the entire fascia is exposed. Okay. And evaluate for the any specific anatomic areas and treat the injuries, and also evaluate for any specific problems like any other problems like carbon monoxide poisoning, any chemical burn, cyanide poisoning, or any electrical or abusive injuries or drug overdose, and manage hypothermia also. And if anything is there, we need to, if any abuse or anything is suspected, we need to notify the authorities. Okay. We'll move on to our next topic, that is compartment syndrome. So, compartment syndrome is not a complication of burns. It can be a complication because of a trauma or a non-traumatic reason. So, it is an increased pressure within a musculofacial compartment, and that will cause ischemia and necrosis to the organ, to the nerves, muscles, or whatever is in that compartment. So a compartment inside a limb is a limited space. So if the pressure increases in that compartment, it will cause bleeding inside the compartment because of the pressure over the blood vessels, or there can be swelling secondary to revascularization. And this thing can also happen if the patient is having a very constrictive dressing or from outside. Okay. So what will happen is, when the tissue pressure increases, the normal gradient between the arterial pressure and venous pressure will decrease. So the normal pressure in the compartment is less than 10, and if this pressure is more than if it is increasing up to 20 mmHg, that can be tolerated without much damage. But if the patient's pressure exceeds more than 30 to 50, then it will be if it is exceeding more than that, then, and if it is untreated, that can cause compartment syndrome, and within some hours there will be damage to the muscles, nerves and blood vessels inside that compartment. Now what is delta pressure? Delta pressure is the difference between the diastolic pressure and the intracompartmental pressure. Okay, so it is most commonly used to diagnose acute compartment syndrome, and the cutoff is 30 millimeters of mercury. Okay. So one thing we need to note, that in a compartment syndrome, the most susceptible or structures to be affected is muscle and nerves, and bone is relatively resistant to ischemia. So the time for ischemia for a muscle and nerve is discussed here. Okay. So in case of muscle, there will be a reversible damage up to 3 to 4 hours, and there will be a variable damage up to 6 hours, and after 8 hours there will be irreversible damage. In case of nerve, there will be loss of nerve conduction up to 2 hours, there will be neuropraxia up to 4 hours, and irreversible damage will occur after 8 hours. Now what are the different causes of compartment syndrome? So orthopedic causes can be tibial fracture or forearm fracture. So when we come to the leg and forearm, there are two bones there. So that is easy to remember. So these are the main main sites where compartment syndrome can happen. So it is in the forearm or in the leg. So secondary to tibial fracture or any forearm fracture. Vascular causes like ischemic reperfusion injury or hemorrhage. Iatrogenic causes like vascular puncture in a patient who is on anticoagulation, or any IV or intraarterial drug injection that is leaking through the vascular structure, or any external constrictive dressing, or soft tissue injuries, prolonged limb compression, crush injury or burns to that site. Then hematological causes like hemophilia or any adverse effects secondary to anticoagulants. So when we come to the limb, so most commonly it is affecting the lower leg, secondary to a tibia fracture. Then next most common site is the forearm. Then other sites are foot and hand. Then only the thigh and the gluteal region and arm will be coming. So lower limb, the most common site is, as we told, the leg, secondary to tibia or fibula fracture. And the lower extremity, there are 4 compartments in the leg. There is an anterior compartment, lateral or the perineal compartment. There is a superficial posterior compartment and deep posterior compartment. So 4 compartments are there. So it is prone for compartment syndrome. Similarly, in the forearm also there are 3 compartments, that is the anterior compartment or the flexor compartment, posterior or the extensor compartment, and a mobile ward. And in the upper leg there is only 3 compartments, anterior, posterior and medial or the adductor compartment. And the advantage here is the size of this compartment is very big, and there is interconnectivity between the compartments, so there is only very low chance of compartment syndrome. Whereas when we come to the leg, there are 4 compartments, and it is there is only less size. So as a result, it is more prone for compartment syndrome. So this is the image of the anterior compartment. This is a leg anterior compartment. the perineal compartment, that is the lateral compartment, and the superficial and the deep posterior compartment. This is the forearm, this is a flexor compartment, this is the extensor compartment and the mobile ward. So what are the signs and symptoms of compartment syndrome? So there will be pain, that is the main complaint. Patient will complain of pain that is out of proportion to whatever analgesics or opioids we give to the patient, and the patient will be having pain on passive stretching of the affected muscles. And the compartment will be very tense and there will be swelling, and patient might be having paresthesia or altered sensation distal to the affected compartment because of the compression to the nerve. Now coming to clinical features, there can be a history of trauma, or if the patient is having on any anticoagulants, or if the patient is having diseases like hemophilia and all, they might not be having a history of trauma itself. Okay, so post-trauma settings can be that usually develop within few hours, or if this patient is having a fracture and if there is a tight dressing given to that patient, then after that patient can develop compartment syndrome. A patient who is awake can complain of pain, but if the patient is sedated or paralyzed or if patient is unconscious, this can easily be missed. Okay, and the pain, the classic symptom is pain which is out of proportionate to the analgesic given, and the pain on passive stretching. Okay. Now, if on examination, we will be seeing if there are slightly palpating muscle groups or pressing onto the muscle, there will be exacerbation of the pain. And what is seen is, usually we have discussed that the delta pressure is the difference between the diastolic pressure and the intracompartment pressure. And usually because of the difference in the arterial and venous pressure, the pulse, the loss of distal pulse will be very much in the late stage. So there will be a palpable pulse. So presence of palpable pulse doesn't rule out compartment syndrome, and it is a very late finding. So no need to check for the distal pulse to rule out compartment syndrome. So how to diagnose this? So diagnosis is clinical. So clinically we need to diagnose compartment syndrome, and we can use some striker kits and all to measure the compartment pressures that can aid the diagnosis. So based on this, we will be able to calculate the delta pressure, and we can calculate the determine whether the patient is having compartment syndrome or not. And early diagnosis is very much important in such patient, because if we are late in diagnosing compartment syndrome, what will happen is the nerves will get damaged. So there will be neurological deficit, muscle necrosis will be there, ischemic contractures can develop, there can be infection, there can be delay in healing of the fracture, and there will be because of the neuromuscular or neurovascular damage, the patient can ultimately go into complete irreversible damage and might require amputation also. So how to measure compartment pressure? So there are several devices, and one is the striker kit which I have told. So it will contain a syringe and a needle, and we will be attaching a manometer in between them, and we will be inserting it into the compartment, and we will be injecting a few drops of saline to it, to confirm that there is no air pockets, and to make sure that we are not inside the tendon, and we will be measuring the pressure, the compartment pressure, and we need to check that in at least two sides of that compartment to confirm. So usually the pressure is very much high within the 5 centimeter of the fracture site, and if it is more than 30, that will suggest that there is a muscular or nerve damage because of anoxia. Then other thing is that we have already told the importance of diastolic pressure to measure the delta pressure, and if the patient's systolic BP is very high, that itself can worsen the compartment syndrome. So this is the manometer. This is how to measure the compartment pressure. Okay. Now coming to laboratory investigation, it is actually of no benefit in case of diagnosing compartment syndrome, because compartment syndrome is a clinical diagnosis, and serum creatine kinase, myoglobins, urine analysis for myoglobinemia, these things are important to rule out rhabdomyolysis actually, and other parameters like coagulation profile, these things comes to play if the patient is taking any anticoagulants, or if the compartment syndrome is secondary to anticoagulants. So management. So management, the management of choice is fasciotomy. But what to do in ED? So in the ED, the main management is a timely diagnosis of the compartment, timely diagnosis of the compartment syndrome, and we need to, if the patient is having any constricted dressing, we need to remove that and elevate the limb at the level of heart, so that it will increase the arterial and venous pressure gradient, so that is a temporary solution. And if the patient is on any anticoagulants, or if the patient's bleeding is because of any conditions like hemophilia or von Willebrand's disease, start on anticoagulation, and immediate surgical consultation and fasciotomy is the management of choice. So surgical fasciotomy. So how to do a surgical fasciotomy? We will be putting a long incision to release the pressure in the affected compartment, and simultaneously we will be incising the adjacent compartments also. So not only the compartment involved, the adjacent compartment also should be opened up. And we should note that because of the tissue edema, there will be muscle bulge and all. So we need to place a long incision, not a small incision just to open the compartment. Long incision is required, so that the entire bulge muscles and these things will escape from the anoxic damage. And these opened fascia should be kept open up to 48 to 72 hours minimum, and a very delayed closure is planned. That means within 7 days or 10 days, the delayed closure of the fascia is planned, and this might require skin grafting also. Okay. The contraindications of fasciotomy, usually there are no much contraindication. Fasciotomy is of no use if we have missed the diagnosis of compartment syndrome, and if there is any delay in doing it after 24 or 48 hours, so that there will be a permanent dysfunction to the muscles, nerves and the blood vessels. So this patient might require an amputation. So in this, that is the only contraindication to fasciotomy, that will require an amputation. Okay. So this is the image of the fasciotomy. We can see a long incision and the entire fascia is exposed, and the adjacent fascias also should be exposed. So that is all about compartment syndrome. We have already discussed about burns also. So burns and compartment syndrome. Okay, thank you.